Hi everyone, I'm Dr. Vikas, emergency consultant from Manipal Hospital, Lanka. So today I'll be discussing about conversion of fibrinogen to fibrin and the role of thrombin in amplification. So I'll be discussing in detail about fibrinogen structure and functions and stepwise conversion of fibrinogen to a stable clot, that is fibrin. And also thrombin's amplification effect on the coagulation cascade and relevant clinical correlations. So coming to fibrinogen, it's a soluble plasma glycoprotein and it is produced by liver hepatocytes and it is an acute phase reactant. Essential functions are clot formation, platelet aggregation via glycoprotein 2B and 3A binding, and it helps in wound healing and inflammation. So this is the structure of fibrinogen. It contains 3 pairs of polypeptide chains, that is alpha, beta, and gamma. The central E domain contains fibrinopeptides A and B. The 2 terminal D domains interacts with other fibrin molecules to build a clot. So conversion of insoluble fibrinogen to soluble fibrin is a crucial step in blood clotting. Whenever there is an injury, it triggers coagulation cascade that activates prothrombin into its active form, that is thrombin, and in presence of factor 10A and factor 5A and also calcium. So this thrombin, what it does is it acts as a protease and it cleaves fibrinopeptides A and B from the fibrinogen, forming fibrinogen monomers. So the fibrinogen monomers, what it does is it spontaneously connects with the fibrin fibers and polymerization happens along with calcium. So thrombin, what it does is it activates fibrin stabilizing factor, that is factor 13A, which helps in forming a stable clot. So the same thing I have explained here. The first step is thrombin formation, and the second is thrombin converts fibrinogen to fibrin monomers. And third step is fibrin monomers polymerize, and fourth step is cross-linking by factor 13A. So coming to the clinical scenario, fibrinogen is the first coagulation factor to fall in major hemorrhage. So when a patient requires massive transfusion protocol, early replacement of fibrinogen improves the survival and decreases the dilutional coagulopathy. So the target fibrinogen levels are, in general, it should be more than 150 mg per dl. And in trauma and obstetric emergencies, it should be more than 200 mg per dl. So coming to amplification, that is the effect of thrombin on amplification. So this is the coagulation cascade. It has 3 processes. One is initiation, amplification, and propagation. So what happens is the tissue factor on a damaged vessel meets factor 7 and activates a little factor 10 and the thrombin on the wall surface. Since this thrombin, what it does is it activates the nearby platelets and also factors 5, 8, and 9 on the platelet surface, preparing a highly procoagulant platelet plug. So this activated platelet along with the other factors, that is activated factor 9, 8, 10, and 5, it causes a thrombin burst, which converts the fibrinogen into fibrin and a formation of effective fibrin clot. The same I have explained here, one initiation phase and amplification with propagation. So coming to clinical importance of thrombin, what heparin enhances antithrombin, which activates thrombin and factor 8, producing anticoagulation. So and also in direct thrombin inhibitors like dabigatran bind thrombin directly and work even when the antithrombin is low. So coming to trauma-induced coagulopathy, reduces the thrombin burst, so the clots are weak and bleeding worsens. So in DIC, what happens? There is excess thrombin generation, but fibrin is abnormal and rapidly broken down, causing both thrombosis and bleeding. Summary is thrombin cleaves fibrinogen to fibrin monomers. This monomers polymerize and a stable clot is formed with the help of factor 13A. So critical in trauma, decisive, and anticoagulant therapy. Thank you.